and good evening, and welcome to Our Hospitals, Our Health. I'm Keith Rose, your moderator for this evening. This is our 38th Our Health program. We're very pleased that you are joining us virtually, either on TV or on your electronic device through some kind of streaming system, or perhaps on the YouTube channel or on Facebook Live. All those options are open. Hospitals have been managing outbreaks and crisis for many years, as long as I can remember. Some of those crises, I look back, power outages, floods, staff, people on strike, doctors and staff, SARS, another big one, fire. What have I missed? Anything? Anyway, and some of them sometimes predictable and some of them totally unpredictable. Anyway, for the last 2 years, we have been impacted by COVID-19 at all of our hospitals. And I think it's pretty safe to say it's a bigger challenge. COVID-19 is a bigger challenge than anything we have seen before because it has gone on so long and had so many ups and downs and so many pieces to it. We're so pleased to have 4 speakers with us, all CEOs from our local hospital. They want to share with us their experiences over the last 2 years and to help us hear their plans about what the future brings for their hospitals, either in the immediate term or in the longer term. So our entire show will be about those particular topics in different time frames. Let me introduce those 4 speakers to you. Carol Lambie, do you want to raise your hand there, Carol? Carol's from Waypoint Center for Mental Health. She's the CEO there. And Janice Scott. Janice, do you want to raise your hand? Janice has the same position, CEO at Royal Victoria Regional Health Center. Thanks to the 2 of you. And then we have 2 old pros that have been here before. Gail Hunt, the CEO at Georgian Bay General, and Carmine Stumpo, the CEO at Aurelia Soldiers Memorial Hospital. Both of these individuals participated in a program in December 2019, if I got that right, I hope I do. We talked about how do our hospitals work. So welcome back to the 2 of you and welcome aboard, Carol and Janice. More detailed biographies of our speakers are in your program. It was electronically sent to you, but if you want to take a look back at it, it's fascinating to see the achievements of these individuals over many years of healthcare experience. There are also some references in that handout that you can take a look at and link onto them. I have some collective thank yous before we start. First of all, to the Our Health Advisory Committee who plan these programs, the topics and the speakers, and specifically to Holly Archer, who did the lion's share of the work behind the scenes on this program. We have 7 local sponsors who I will acknowledge at a later time in the show. And we would be remiss not to acknowledge the wonderful staff at both Rogers TV, Josh and Laura, who are here tonight behind the scenes, and Michelle and Victoria and all the rest at the MCC who make this happen. So thank you to all of you. We're going to deviate a little bit tonight from our usual format. This is going to be more of an open forum rather than an individual discussion with 4 speakers. We'll be addressing key areas that were important over the last 2 years and will be going forward. For example, those key areas that I have listed down are things that are internal to the hospital, things like patient care and the staffing. There's some others too I have on my list, but those are 2 important ones. And then some external challenges, the community services, the community people, the Ministry of Health, their directives, their guidelines, their finances, and of course, public health, who has been near and dear friend throughout the entire 2 years and still continues to follow everything on a daily basis. So During our interactive discussions, I'll ask our speakers to address these things, and I'll put them in an order. But I'll also ask some questions that we've received ahead of time from our audience. Thank you for sending them. There were several this time. And I'll weave them in amongst our conversations. But if you've got a burning question that you want to send, just use that Facebook Live chat line or use the email address, the mccrhealth@outlook.com address that's being monitored. And Michelle from Rogers will feed me back those questions. So, thanks. So at this point, I'm going to turn to a discussion about patients in our hospitals and what's been happening to those patients, whether they arrive in the emergency department, whether they're on a medical ward, whether they're on a surgical ward, obstetrical ward, in an ICU. How have you managed all of those patients? And Carol, you were helpful to say, some of the patients have COVID and they come in with COVID. And there's some of the patients who get COVID, test positive for COVID, and they're another group that are quite different. And then there's all those healthy patients that are trying to get better from some other disease unrelated to COVID, which are the majority of your patients. So talk to me a little bit about your experience, Carol.
Sure, thanks, Keith. And would welcome the comments from one of the acute general hospitals afterwards, because our experience has been very different in mental health care. So patients we don't have an emergency department, patients wouldn't present to our emergency department. So what you're differentiating, Keith, are patients who are admitted for COVID or patients admitted with COVID. All of our patients would be admitted with COVID, not for COVID. And what we did very early on, immediately at the beginning of the pandemic, was opened up a new unit that we had not had in operation, so that all of our admissions could go through that unit, be tested, be isolated. And so that changed the entire patient flow throughout our hospital. And that continues to this day. The other thing that we found, and I'm sure we'll talk a bit more about the impact of the pandemic on mental health and addictions, we've certainly seen an increase in that number. So we're operating additional acute mental health beds. And what we're finding in the system is there's a real need for psychiatric intensive care beds, and there is a shortage of them across the province. So as the other hospitals talk about patients moving, and I know, RVH and OSMH receive patients from Toronto hospitals, we did in a different way as well, because there were not adequate mental health beds. And so with our additional beds, we have been admitting patients from Toronto hospitals for mental health and addictions, and that's something that would have been more infrequent prior to COVID, for sure.
Was this an established arrangement, Carol, or is this something that developed on the fly, or did this take a directive to do it?
Well, I'm not sure which you're asking the question about, but certainly setting up the new unit was just something that we did internally to address infection prevention and control measures, patient flow. In terms of taking patients from, we've taken them from Unity Health, St. Mike's, for example, South Lake. That has come about through a GTA IMS mental health and addictions table, where we're looking at patient flow right across the province and capacity and room to be able to take patients, so that, we saw our role as freeing up emergency room capacity in the general hospitals from mental health patients, because that's what we do, as opposed to surgery, ICU, and emerge departments.
Thanks. Janice, what kind of feedback have you had from your patients? And you've got a wide group of patients. An obstetrical patient is very different than a mental health patient. A patient that comes in suffering from COVID is very different than a patient who's recovering from a surgical operation. But how have you kind of looked to make sure that all those patients are getting the care that your staff has always been able to give, but in challenging times, how have you managed?
Thanks, Keith, and good evening, everyone. Certainly, what we continue to do throughout this pandemic, I think, Keith, you mentioned the most important thing. As healthcare administrators and in healthcare generally, we're used to pivoting and rolling depending on what the crisis of the day is. That's sort of what we do. But I think what's different about this pandemic, obviously, was wave one and wave two. Rules were changing almost every day. And of course, now we're talking about a 2-year period of time where it's been grueling for our frontline staff to be able to get through this. So I always want to start with a big thank you to Team RVH because of the incredible work that they do. And what's been really interesting to us, because we haven't had visitors, we've had patients who have with a lot of unknown issues they're dealing with, we've had a pandemic response unit, all of those things together. But our external company that actually does patient experience scores for us have informed us that actually our patient experience scores, which is about would you recommend, have gone up during the pandemic. And I think that really speaks to values and being a very values-driven organization. So I just couldn't be prouder of RVH.
So what do you think made the difference? Why, Carol? I'm going to push you a little bit, or Janice. Why were people happier in a time that was most the external news was quite distressful?
I'm not sure if we'd say that patients were happier. I think patients would be saying that they were grateful for the care they received exceeded their expectations. They felt safe. And so when we think about how the public was so concerned, rightly so, about the spread of this disease, when you come to a hospital, it's what we do every day. We know how to function in PPE, we know how to take care of patients. And I think when patients came here, they felt that they were safely being cared for. We took care of 250 patients from the GTA along with our colleagues here. And there were many stories of people not wanting to go back to their other hospital. They'd never been north of 407, but they found themselves in a facility with competent people and caring people. And so that was part of our experience as well. So I think it was not about happy as much, Keith, as it would be about feeling safe on the environment and grateful for the care. And even though our staff were stressed and tired and hot from all that PPE and worried about their families at home, that there's an unrelenting focus on making sure there was a positive patient experience.
Okay, thanks. I guess the other thing that maybe our audience doesn't realize is that many of those patients that came from the GTA, you didn't actually have to have their permission to send them here because they really did need to unload some of the GTA hospitals for whatever reason, their own complex issues, so that patients were told they were going. Now, I'm sure that they worked at it to make sure that it was done in a careful way as possible, but at the end of the day, the issue was patients were going to move between hospitals. And this is very different than perhaps years ago in SARS when it was more voluntary than it was this time around. Anybody want to comment on that, what the effect was on you or how you felt about that?
I think patient consent is still very important. And obviously, if all you can do is get maybe a stretcher in a hallway and you're told you're going to go to an inpatient bed and that this is part of a system solution. And in some cases, of course, from directly into our intensive care unit, that really wasn't a conversation. But I would say overall, there was still an opportunity to communicate with patients and families, particularly because they knew then they'd be coming into a bed itself.
Okay. Gail, I know you wanted to talk about visitor policies and the challenge that was to tell people they couldn't visit their loved ones and how you managed that and the ups and downs of that.
Yeah, thanks, Keith. It was definitely probably ethically and emotionally one of the most difficult parts for the teams, for leadership, and for, of course, our patients and visitors. Immediately when it started, we all shut down visitation, and situations that you couldn't predict in those moments occurred during that time. And really staff just wanted the protection of knowing that there was no additional exposure for them, for the patients. So I think on the front lines, it was very black and white. Protect us, protect our patients. We can't have visitors in because we don't know what they're doing. We're trying to maintain our facilities with no outbreaks. But you have people in their, lowest moments of life, or palliative patients, or, really challenging situations that visiting your loved one on an iPad, if you have that ability to do that, is just, is not a replacement for that. So dealing with that, we got better as this evolved, and we realized situations where, in the emergency department, just, most likely need support persons. having really clear escalation processes for families and patients to appeal to when they didn't agree, because we have situations where families have a palliative. We set the limit at 4 patients, and family from a province away drove over all night to be here, get to the front doors, and we're telling them, well, here's an iPad, you can visit them. So being flexible enough to deal with those situations and address them in the moment is definitely one of the most difficult times, because we saw fall rates go up. We saw patient behaviors, those who have behavior issues or dementia related issues. It was much harder on the staff to manage those situations because they were so busy, gowning and doing all the PPE steps, and then normally you would have family in to help you in those situations to keep the patients busy or keep them calm. And then those situations change. And so the burden overall, the burden on the patients not getting that support, the burden on the staff also not getting that support. But at the same time, we had visitors bring in COVID to patients, because it's really hard for people from that familiarity complex to say, I know they're at your house yesterday and you were caring for them, but today you have to keep a mask on and going forward. And people can't logically make that connection that they're getting exposed to different things now. It's not the same. So we saw transmission in and we saw transmission out, where visitors caught it because they didn't follow PPE when they're with their loved one, and they caught COVID. And then, were very ill and having to be hospitalized. So it's really about, trying to make the decisions based on the least harm. But it has been a really difficult situation. I know in long-term care, it's been extremely difficult. At least for acute care hospitals, we don't usually have patients here for extended periods of time in most cases. But it has had, I think we'll see the effects of these decisions for years to come as people process what happened and how they didn't get maybe those last moments with a loved one, or weren't able to support, or weren't able to be the support person for a birth of their first child, or something like that. Those are all going to have ramifications for the years to come. But not everything's black and white. There's shades of gray, and you have to make the best decisions with the knowledge you have in the moment.
So, Carmine, let's move ahead a little bit. And currently, we're seeing the numbers of patients with COVID decreasing substantially in hospitals, which means that means hospitals have beds for other people to admit to if they have the staff to look after them. But it does mean that you're starting to have to plan ahead. How do you reopen? What services do you do first? Is there some clear direction around that? What are your plans to OSMH for, I'm not going to call it reopening, and I'm not going to call it getting back to normal. I'm not sure what I should call it. You tell me what I should call it.
Thank you, Keith. Let me think about that one, because we've been down this path and several times. I'll start by saying we are certainly seeing reasons for optimism with the declining rates of COVID. However, we're still not at zero. I know many of our hospitals have active cases still happening, and we always have to reserve that capacity to be able to respond, particularly now that we see that the province is reopening, there's more mobility. We need to be ready, and I think that's well articulated by the Ontario Science Table, just to anticipate that there will continue to be bumps along the way with cases. So we keep that in our minds. The other factors we're looking at as we emerge from this wave is we've seen unprecedented growth in all of our communities. In Aurelia, we've seen recent census data shows growth we've never seen before. And that's pretty obvious, a reflection of the pandemic and people moving out of the GTA, and those individuals come with their care needs. We've also recognized that people may not have been receiving all the care that they probably should have over the last 2 years. So there's unmet healthcare needs, not just procedures, but just basic unmet healthcare needs. So over time, those needs become more and more urgent, and they present themselves in hospitals. So you have an ongoing COVID burden we have a growth in population, a growth in healthcare needs of the population. And then we start thinking about, okay, how do we start to tackle the surgical procedures that have been canceled in multiple waves and work our way through that list. So it is quite daunting when you look at it from that perspective. We recognize that we really need to be working at this for some time. This isn't going to be a very quick fix. We need to build the capacity within the system to be able to respond. Many of us just started to open up our operating rooms to scheduled activity. That's going to be a slow progression as we ramp that back up, and it will take us some time to get to those cases that were deferred. And then there's all the other work that happens within the hospital that we start to be thinking about our strategies, our next steps in programs that we want to see grow and develop, which may have taken a bit of a back burner for the last little while as we work through this most recent crisis. So the strategic planning, the healthcare planning, the response to the ongoing needs becomes a very complex array of different factors that we're trying to keep an eye on a regular basis, and at the end of the day, serve both from the immediate needs of our population and start to work at those deferred needs that we've seen over the last 2 years.
So I had a very personal interaction with a neighbor of mine a couple of days ago who's waiting for hip replacement surgery, and she said, I just hope they know how much pain I'm in, how difficult this is. And I know nothing. I don't know when. I don't know, where I'm at on a list, because it's obviously gotten way behind, not just the 4 weeks that we've been shut down. What kind of plans do you have to communicate with patients about when their activities will actually come to the front of the line? Janice, what do you do at RVH?
Sure, and just building on Carmine's point that we have 7,000 elective procedures that are behind as a result of 3 ramp downs, so cumulatively. So it's quite significant. But what I think the positive is that we've been able to keep 4 to 5 of our operating rooms open during the pandemic, and certainly every day, as much as it's been very difficult for our surgeons, anesthetists, and nurses not to be able to perform those services, they've been every day monitoring what might become urgent or what is going to become emergent. And therefore, they've looked at that list and changed it. So now that we're back ramping up at 70% of our 2019 volumes, we're now communicating with our patients about where they sit on that list, knowing that it's a dynamic list, meaning if your case does worsen while you're waiting, it's between your surgeon and the hospital to ensure that in fact you're going to be moved up on that list. So it's not really about how long you've waited as much as this constant priority setting to make sure we can move forward. We want to get to a fully functioning operating rooms very soon. And we do know that everything is going to take a little bit longer because there are new protocols and procedures in place to make that happen. And so we encourage people to speak to their surgeons' offices, calling RVH. We'll be reaching out proactively to make sure that people know where they're at. It's been just, I guess, a week or two that we've been moving back into the ramp up procedure.
Mm-hmm, mm-hmm. Yeah, it all happened so quickly, both ways. So tell me, what are the things that you put on hold in terms of planning things that were important from your perspective? They were add-ons, they were ways to do things differently from a patient care perspective. Are some of those things you put on hold, or have you learned new ones throughout the last 2 years? Gail, tell us about that.
Well, I think I can, if Janice will permit me, I'll talk about a big thing we put on hold several times during COVID as a partnership of 4 hospitals with GBGH, RVH, Headwaters, and Collingwood. We completely changed over our electronic medical record system as a joint partnership and sharing one patient record amongst the 4 of us, which started way before COVID. And we actually had to delay the project twice, which is a huge undertaking, and it cost additional funds to be able to do that. But we had to look at the capacity of our teams. We had team members assigned to this project to build these systems. These are huge systems that handle all our clinical pathways and everything in our from dietary to all the advanced clinicals. So it takes a lot of work to build them. It takes staff involvement, and we had to pull staff off those projects to be able to put them back on the front lines. So that's exhausting for staff. You know, when we tell them it's coming this January, and then we tell them, wait, no, we're going to go to the fall, and then we tell them, oh, there might be another wave coming. And as leadership's trying to decide, should we go? Do we think we're going to have enough time before the next wave? And you know, you build up that optimism that, oh, it looks really good now. We're and I am very happy to say, as well as Janice, that you know, we did finally pull the trigger, and thank God we did when we did, because it went just before this following wave. So staff were able to get trained. We launched. They were able to do a little bit of optimization work before we hit this. But you know, when you take on a huge project like that, it's a multi-million-dollar project, and then you say we're going to pull everybody off and we're going to stop. And then by the time we did it the second time, had to delay. Our discussions were, if we have to delay one more time, are we even going forward? Because how much longer can we do this to the staff? We're on, we're off, we're on, we're off, yeah. And our caretakers. And it was exhausting for the staff to get trained for this new, but it evolved patient care. We're now paperless for our patient care. There's no more coming to the emerge to, you know, try to, you would know, Keith, as a physician, that physician handwriting is something to be suspicious of. So all these things and the connectivity and being able to share the patient record between our sites so that, you know, whatever the nurse writes in one hospital is viewable to the care team when they get moved to another hospital of our 4 partner hospitals. So we really evolved in our electronic medical care here, and it's going to allow us to do so many things. And, you know, I think as a team, as 4 hospitals, we're really proud of the teams for being able to do that during COVID. Because it was a huge change management, a huge accomplishment, and this pandemic was happening at the same time. So, you know, we got through it, and I think that we're all really happy that it's over and we're, you know, on the other side of the mountain and just working on optimization. But it was, you know, it was really nice to accomplish something like that during the pandemic.
Hats off to you. Big change management program. It's not just about, it's big change.
Somehow we squeezed it in between 3rd and 4th wave, and I couldn't have known there was going to be a 4th, but you know, just this beads of sweat, and we said we did it, and obviously our partnership strengthened from it as well.
Right. Carol, tell us about Ontario Health Teams and going forward, what difference it's going to make. Because as I look back, Ontario Health Teams, many of them have not been established more than 3 years, right? That was time. And yet you've had now a pandemic, which has spread out your interest to other more chaotic things at times. So what do you see coming down the pipe with Ontario Health Teams in terms of improving services for patients?
That could probably be a program in and of itself, Keith, in terms of Ontario Health Teams and sort of their infancy, I guess, the initiation prior to COVID. There were Ontario Health Teams right across the province at different stages of maturity. And then pivoting during COVID, many of them turned their focus to supporting the partners through COVID, meeting the needs of all the partners as well as the patients. And now coming out the other side, again, like we've been talking about other projects, looking at what were their priorities pre-COVID? Are they still the same? Ontario Health Teams all identified priority populations. Some of them have changed over the course of the pandemic. And so I think there'll be a bit of a reset there. The traditional Ontario Health Teams that my colleagues are involved with would have a focus on the acute general community hospital, primary care, and home and community care. We're involved with a specialized Ontario Health Team providing services to a broader geographic area and focused on specialized services. Our priority populations we've identified are mental health and addictions, which should be no surprise, but beginning with children and youth, seniors, beginning with specialized geriatric services, and our Indigenous community led by our Indigenous partner. We've continued our focus, although we've continued meeting regularly. We've continued with our work around integrating, for example, clinical pathways with primary care for children and youth experiencing anxiety and depression. So all of that work for our Ontario Health team actually continued through COVID. We did at each meeting check that, that the partners had the PPE supplies when that was a pressure, and other issues related to COVID. But for the most part, we've actually continued our work. And that work involves liaising and partnering with a myriad of other Ontario Health teams, particularly those that have also identified those priority populations. So using mental health and addictions as an example, if each Ontario Health team, and depending on the size of the population they're serving, may not have the resources in a step care model to be looking after tier 3 or tier 4 specialty services. And so we see our role again as supporting those patients needing specialized services and those Ontario Health teams that may not have those specialty services because they are not to be found. There wasn't that great a supply of them, and so not every Ontario Health team would have those. So many partnerships, and
the team which looked to your focus as one area, but there's a bigger team across all of Ontario as people are looking at where services can be shared and who can do things best and how you get those patients to those areas. So thanks, Carol. Anybody want to add anything to our discussion around patient care, past, future thoughts before we?
I do.
Sure. Okay.
I think, when we think about patient care, we really do have to think about lessons learned and where we can't go back. So my example would be hallway medicine. We had so many patients being cared for in hallways, in makeshift rooms, and it was unsafe. We always knew it was not patient-centered, but it's really unsafe. So we have to find a way through that we won't be going back to hallway medicine. I think secondly, we have to make sure we have enough critical care beds. We operate 16, for example, at RVH. We have a proposal in for 15 more, but there's been a commitment made that we'll never find ourselves in a makeshift environment for the most ill patients in our province, for sure. And therefore, although for the decade or longer, maybe most of my career, we've really been trying to sort of balance this budget on a bit of a shoestring and making cuts, et cetera. But really, when we found ourselves in this pandemic, we've hired 300 more people at RVH just to manage within the pandemic itself. And we can't go back to the way that we were either budgeting or we were being funded. It's really important because if we're going to retain staff during this time where health and resources are already really strained and more baby boomers are retiring, we just need to find ways and strategies to make sure they feel safe at work, and therefore they have a complement of staff who are trained and ready to support them. So I think those are really key lessons learned, and we need to ensure that when this broad provincial document is written about lessons learned from this pandemic, that we all advocate for those recommendations to be implemented.
Okay, so you have a direct line to David Naylor, do you, when that document's going to be written? Good. Carmine.
I want to reiterate that there's a couple of lessons that we cannot let go unnoticed, and the capacity issue. We can't keep shutting down the economy, shutting down the province to protect hospital capacity. We need the right hospital capacity, and that's how we can continue to function as a society through all the bumps we're going to see in the years to come. So properly sizing, we've seen growth as well in all areas of our organization, and quite frankly, we've become landlocked with an inability to expand in beds, given the 45 extra beds we've had to open. The other lesson I think we need to take away from this is going back to Carol's point around OHTs and integrated care. That became more important, not less important, during the pandemic for us. It was our Ontario Health teams, our partnerships that responded to testing at the beginning, COVID testing, vaccination. They responded to COVID therapeutics as the antivirals came out. Very important elements of our COVID response. It was our Ontario Health team that really mobilized to address what we call high intensity supports at home. We all saw that it was much harder to get patients home during a pandemic. It was harder to access services at home for some of our long-stay patients. And using our partnerships in the community, we were able to mobilize a team to get out into the community, serve these patients where they wanted to be, where they wanted to have their care. And it may have necessitated multiple visits per day, but it was always better than being in a hospital during a pandemic. So that kind of integrated care is going to be essential going forwards.
Okay, thank you. Thank you. I do want to move on to your staffing at this point. Somebody said to me, why are you so surprised about staffing was a problem? Because people have been talking about hospitals understaffed for a long, long time. Not enough doctors, not enough family doctors in particularly, not enough nurses, not enough critical care nurses. We certainly saw it in the long-term care homes, not enough staff, but it didn't happen because of COVID. It happened long before COVID. So tell me how, you go into it and you say, I wish somebody or I'd done something about it before, and yet now I've got this thing out there, this pandemic, that's going to make it worse. And how did you cope with that? How did your staff cope with that?
I can start. Yeah. I think that, that definitely, it did exist beforehand. It was exacerbated through COVID. And I think the hospital sector, I know, has been advocating for some time for government to have a closer relationship between education and healthcare, because changes are made on either side and have significant impact on each other. When there aren't enough offerings of seats in schools for health professionals, we see that in our workplaces years later. And an example we saw during COVID was when COVID first hit, hospitals immediately shut things down, and we shut down student positions. We kicked all the students out because we wanted to protect. The staff didn't want the stress of having an extra, person to look after. And then we started putting a lot of pressure on the post-secondary institutions to fast track students and get them out, because and their response was, well, we can't graduate anybody because they can't get their practicals done because you won't let them in the hospitals and you won't let them in these healthcare sectors. So there is a disconnect that exists. And if we think about how we plan for this going forward, there has to be a real marriage between healthcare and education so that we can make sure that we're on both of sides are not making decisions that have very significant negative impacts on the other. We need to plan together about what the future looks like. There's no quick way out of this. We are looking at different staffing models of maximizing scopes of practice in the short term to get us through, as well as different international options. But going forward on a proactive basis, there has to be a better relationship where I think the universities themselves would love to be working closer with us, but the ministries of these two different sectors need to be working closely aligned as well to make sure that those plans are coming from a top-down endorsement per se, so that we can get out of this sort of cycle we're in.
So how are you going to create this flex in the system so that you're ready, so that even ramping up, you're doing everything, and all of a sudden you've got an outbreak on 2 wards, which means you can't admit patients to those wards, or it means that it significantly curtails your patient. And of course, you've got an outbreak, and that means you've got staff that's probably off too. So are you going to create some more extra capacity in the system? Can you do that in terms of your staffing? Dennis, you're retiring. You're going to give us some advice.
There's just so many things going through my mind. First of all, I really agree with what Gail had to say, and also really some innovation around health human resources. For example, the extern programs. We get to bring in final year students in all different disciplines. They work with us under supervision, and we hope that they stay. But these are the pathways that we have to create to make sure that, in fact, we can recruit. But we also have to really focus on retention. And what is really important for us, all of us say, is the staff are exhausted. So whenever we think we're going back to this new normal, I'm sure Carol will comment from a mental health perspective, but whenever we go back to this new normal. We have to make sure that we're going at a pace of change, that we don't lose more people because of the system changes, and that everyone is quite fatigued. Frontline staff, but also I think the unsung heroes, honestly, are our middle management, managers and directors who work so hard for the last 2 years. So what we do right now, we will do it every time that there's a unit outbreak, or for example, we've had 600 staff off with COVID positive, and 76% of those have happened since Christmas, just to get sort of a handle on how significant that has been. But we have a deployment mechanism where we continue to try to bring people in and out of the system, in and out of different units. We've tried new care models to make sure that it works. And certainly, as I mentioned earlier, we've hired up 300 staff to try and manage this. And what is important as we go back to whatever the new normal is that we need the operating funds to retain those people. We can't go back to trying to balance this on a shoestring budget, as they might say, because it just isn't enough to not only keep it safe, but also to keep our staff who are so fatigued from going through this for the 2 years and sticking with us and doing obviously their very best. But we have to be very aware, I think, of the mental health of our teams, both at the front line, but also in management. Carol?
I want to hear from Carol, and then quickly, Carmen, I want to hear from you around what you did creatively to bridge a gap. Carol?
Yeah, thanks, Keith. You mentioned this is not a challenge made by COVID, but it certainly, as Gail said, is exacerbated by COVID. We've added over 3,000 beds across the province. And adding beds isn't helpful unless you add the staff to go with them. So, Janice talked about the increased number of staff they've hired. We have as well. We've been using agency staff for the first time in, the history of the hospital. So we have all scrambled to do what we need to do. The Ontario Hospital Association is advocating with government to put together a plan that thinks a little bit longer than short term, medium term, longer term, identifying, we need more than 10,000 RNs, 3,500 RPNs over the next 5 years in the system. So to Gail's point, we have to partner with academia to get those individuals trained and into the system. I guess one of the other comments that I would make is we need to look at this across the system, not simply hospitals. There's certainly wage inequity between hospitals and long-term care, between hospitals and community providers. And when that is not addressed, we just have people moving around the system, and that's not necessarily helpful either. So to Janice's point, retention is really important, but I would say that is the case across all of the providers in the system. So certainly focusing on organizational wellness and how we can support our staff is one of the areas we're keenly working on.
Okay, thank you. Carmine, during the January tough time when you were short-staffed, you did some creative things. Do you want to tell us what you did?
Sure. So I'll start by saying I completely agree with my colleagues. The education system and working well with that and retention are key medium to long-term strategies. What we saw in January when we went through the scenario of 2 simultaneous outbreaks and recognizing we had care needs and multiple staff off with COVID or exposed to COVID. At the same time, we recognized the province had scaled back and had reinstated the restrictions for a number of businesses. So our immediate reaction was to reach out to those businesses that included Casino Rama, the City of Aurelia, Georgian College, to see if we could recruit those that were displaced. So we had a pool of individuals that were skilled in the ability to screen and provide some levels of support in the organization. We immediately interviewed, hired, brought them in, tried to minimize their gap in wages, and they really appreciated that. What they were able to do is allow us to redeploy our existing staff that were familiar with the hospital into the organization, supporting our nurses on the front line, supporting all the areas of the organization. It lasted several weeks, but it was a real boost to the headcount to get more people working when a lot of people were sick. And symbolically, it was really important. It was the community supporting us. Our team members really appreciated it. It gave them a sense that, yes, we're all in it together. And having talked to some of these individuals, it really gave them an opportunity to be a part of this COVID response on this wave, and they really appreciated the chance to work. Thankfully, the restrictions weren't long lasting, so they weren't with us for very long, but it certainly made an impact. And it really, again, we talk a lot about relationships, and it really, the entire process of working with those organizations was very positive in sharing the staff.
Well, it'd be interesting to know if you actually do recruit some of those people in the long term into healthcare.
We promised we wouldn't, but it would be their choice.
Okay. One quick question on some things related to staffing. Whoever wants to answer. When are the volunteers coming back?
Not soon enough. Again, it was one of those quick decisions made in wave one where it was all about safety. And so we had to ask our volunteers to stay home. 700 strong at RVH, we call them our Blue Brigade, and they are really the heart and soul of the organization. And who knew that it would be 2 years before we were able to see them back into the organization. So many quick decisions in those first waves. And then with all that's happened, it's just impossible. But we are committed, and we have a plan that will bring our volunteers back into our organization when it is safe to do so. So the plan's in place. It's the when that we're not really committing to, because we don't want to start and then have to stop again as we've watched each of these waves go through. But without them, not just providing the extra hands, but really their enthusiasm for being here. So I want to thank those who are at home and also doing work for us at home. Many blankets are being knit, a lot of other resources coming together at a distance for us, but know that we miss our Blue Brigade and we look forward to welcoming them back.
Okay. Gail, one final comment on this, and we'll...
Yeah, I have to say that same thing. It was hard. We've had a few in between waves that come in and done some, safer thing, but thank you to our volunteers as well that we redeployed our volunteers as well as we've done with staff, and we actually had them volunteer and assist at the public health vaccination clinics during this time. So everybody gets redeployed during COVID, not just staff.
Yeah. Okay. And I want to include your board members and your foundation and members as volunteers too. So collectively, all of those people continued to work. I don't want people feel that they took a break during any of this. In fact, they probably doubled the meetings for them, right? Okay. At this point, I'd like to take about a minute and a half break just to formally thank our sponsors and tell you a little bit about the next program. Laura or Josh, can you put up the slides for the sponsors? Great, thank you. So we have 7 sponsors who give us some money at the beginning of every year that goes to allay our costs of promotional material, renting of the MCC, camera material, and all those other things that go on. And I would specifically like to thank the Center of Psychology and Emotional Regulation, which is headed by Anita Federici, the Audia Hearing Aid Center with offices throughout Simcoe County, Waypoint Center for Mental Health Care, our newest supporter, Hillcrest Village Care Center for a long-term care home managed by the Enns family, Mink Insurance led by David Mink, and now it's called McDougall Insurance, I think, and Georgian Bay General Hospital, longtime supporter of our program. In addition, Lois Lipton, the Lipton Group, specialize in commercial property and real estate. So thank you to the 7 of you. And, it's not just the money they provide us, it's the community support that they provide us, the ongoing communication we have with them. They're sometimes the people that are suggesting our topics. So we really appreciate the input of our sponsors as well as their financial support. Our next program is 7 weeks tonight at 7:30 p.m. Again, available on TV and online, and hopefully to an audience at the MCC, but we'll wait and make that determination a little later. The topic is, will the kids be okay? And we're delighted to have recruited 3 really key speakers, a pediatrician who works at Waypoint, I think Carol, you know who I'm referring to, Rob Meter, a camp counselor, Rich Birch, and today the latest recruit, the principal of the high school at Georgian Bay General with the Simcoe County Board of Education. So people that are well informed and hands-on with our kids and where they're going. And I'm really looking forward to that 7 weeks tonight. So see you then. Now we'll flip back to our discussion. And I'm not going to flip to our question period just yet, because I certainly have integrated some of the questions that I've received in our discussion so far. So let's flip to outside. Let me talk about public health for a minute. And Charles Gardner, the Director of Public Health for Simcoe County, Medical Officer of Health for Simcoe County, Muskoka, is a well-seasoned healthcare worker, and he has been guidance for a lot of our programs in the past. And so I let him know about this program, and I said, did you have any words you wanted to say? He said, thanks for recognizing public health. He wanted to acknowledge the tremendous challenges that our hospital has faced and continue to face in the response to the pandemic, as well as the critical importance of their contributions to the overall response. He mentions the assessment and care of cases, the establishment and support of assessment centers, infection prevention and control, and outbreak support to long-term care facilities, and assistance in the provision of vaccination. Throughout the pandemic, the partnership, again, we're hearing this phrase frequently tonight, between public health and hospitals has been crucial and will remain such as we continue in our response to the pandemic of the centuries, he said. So Charles has certainly appreciated all of your support, and I know you probably have appreciated his. Public health is always an interesting organization, because they're essentially responsible for the health of the community, and the overlap with hospitals, regular times, not very often, right? I mean, there's some, but not a lot of, maybe for a few outbreaks. But tell me, where do you see public health in the future? Where do you see your interactions with them? Sometimes they act like a regulatory body. They tell you how long you should be closed, what you should be doing. But how do you see that evolving, that partnership that Charles refers to? Who wants to take that one? Carmine?
Sure, I can get us started. First, the world of respect for everyone at public health. That is one of the most difficult jobs. 2 years running in a pandemic, carrying that burden of being on top of so many different aspects in so many different communities. So absolutely hats off. And I'm sure we'd all agree we spent more time with Dr. Gardner in the last 2 years than we have in a very, very long time. And I think going forward, there's a mutual respect and appreciation with public health. Their challenges, how they operate, and their decision points, and it's not simple. It's locally. There's provincial guidance that comes down, and we work within a region that has multiple public health offices, and there's always going to be some variability. And you're trying to not only give good guidance, but help people interpret it and apply it within their communities, within their hospitals. By the same token, I believe that public health has done a great job trying to understand hospitals more and see some of our challenges. We know in outbreaks at one point, the traditional rules just can't apply anymore, because when you're talking about an Omicron pandemic where every hospital is working through outbreaks, some hospitals multiple outbreaks, you just can't operate the same way, and there needs to be flexibility and creativity in how we continue to serve our communities. And I really valued the fact that we were able to work through that. We were able to, with all levels of public health, to be able to navigate some very difficult times together. And I think that's a value, and also the success story. So being a part of assessment centers and vaccine clinics where the mood is typically much more positive, where people are receiving vaccines as an example, and working with public health closely on that. There's some really good positives. I know we will carry through in terms of our relationships.
Okay. Anybody want to add anything to that about the relationship with public health now and into the future?
Sure. I could jump in to agree with Carmine and really recognize Dr. Charles Gardner and his team as well. We work so closely with the entire team, and I think the mutual respect has grown, and certainly we'll see that well into the future. So if we don't spend more time and resources on staying well, again, giving this population shift to the aging baby boomer population, the bulge in it, we're never going to have sufficient hospital resources to manage. So we really, the pandemic, what's no waste of crisis. So many of the positives from it would be, one would be a strengthened partnership, public health, mutual understanding of our roles and responsibilities, working together, and we need more emphasis on public health and prevention if we're going to weather through this next couple of decades.
Okay, thank you. Thank you. Let's talk a little bit about the community around you beyond the doors of the hospital, but where the patients come from. So let's talk about your relationship with the community, your communication to the community. I know, Gail, at one point you said, putting out these visitation policies to the community wasn't an easy thing to do. We didn't really want to do that, but you did it anyway. But how did you manage that angst with the news that was going on and what was going on in your organization from a communication to the community? Gail, do you want to start that?
Yeah, for sure. Janice mentioned unsung heroes earlier, and definitely our communication staff have been a big part of that. The complexity of pivoting and having new directions come out all the time, and having to communicate that in an orderly fashion as quickly as possible so that we can tell our staff, make sure they're well oriented to it, tell the public. A further complication for GBGH is our French designation. So we're having to put out information in both official languages at the same time throughout this. So the layer of complexity of trying to inform the public, but not give them, at the same time, we tried to add in a tagline all the time to not discourage them from coming to the emergency department, because as soon as this started happening, whenever we're trying to communicate that there should be cautious, or if we had an outbreak, we see our merge volumes drop. That means patients aren't coming in for care, and we experience that boomerang effect later on. So we really tried to say, encourage you, if you're concerned, we're concerned, come to the emergency department. It is safe. I mean, it's probably it's way safer than going to the grocery store. It's way safer than any of those, the public venues you're going to. Please do not hesitate to come. So it was, every time we were sending out a warning about something or a new direction, always put in there, if you need care, come to the hospital. We're here for you. We'll take care of you. We'll keep you safe. So balancing that communication was very difficult throughout this, to make sure the messages get out. And as a region, we also wanted to, we instigated a lot of work amongst ourselves, just making sure we standardize our messaging as much as possible. Hospitals are very used to having a lot of autonomy. So getting, a lot of hospitals to work together. We had strong relationships in this region, but we made sure, we meet on a regular basis. Carbine's been good enough to strike up chairing a North Simcoe local meet group for us in this region. But we made sure that, our patients travel between hospitals in this region. We have to be communicating out the same messaging to them. We can't have varying degrees of visitation differences or policies when they come into the hospital. So even when we waived parking, we all did it together. We discussed when we reintroduced paid parking. All those things we tried to do together so that nobody was it wasn't confusing for the public in our communication. We kept our municipal reps up to date on what we were doing so that when constituents reach out to them, they would know what was happening and why it was happening. So all this is happening at the same time. It was very complicated, but I think, kudos to all my colleagues that we managed to, stay friends throughout it. And we managed to standardize as much communications as properly. And it was tough times, and we got through it. So,
Carol, what key messages did you have?
Various statistics, changes, as Gail said, certainly in the early waves, the changes were coming fast and furious. And I would agree with Gail, our communications teams worked really closely together. The CEOs, did as well, set the direction. It was important to identify all of the stakeholders that we needed to communicate with and use various modes of communication posted on our website. But we have a community leaders forum where people can ask questions. They get concerned. It's a small community, and so people wonder what's going on. Is there an outbreak? Is it safe to go, as Gail said? So we held number of those meetings regularly. For us, more than half of our inpatients, we serve the whole province. And so we have patients coming from all over the province, and their families are still in other communities. So identifying patients' families as an important stakeholder. We have regular bulletins that go out to them. So I would agree, our communications folks have been very, very busy over this period of time, just getting messages out as quickly as possible. Internally, we've had regular, bulletins and staff live addresses where people, I just provide an update and then staff can ask questions. And that's been very well received across the organization. So lots of stakeholder groups and lots of methods of communication, internally and externally.
Thank you. Janice, thanks for putting up your hand. I was going to volunteer you anyway. I'm going to ask you specifically about cancer patients, because there's a group that, 50% of people will have cancer at one point of their lives. So a large segment of the population, which is waiting to see somebody, waiting for diagnostic tests. And a lot of those appointments didn't happen the way they used to happen. So how have you communicated lessons learned going forward?
Thanks, Keith. I too want to give a shout out to corporate communications at our reach. It's a really good point, Gail. Secondly, before we just get right to cancer, I just wanted to say the media played a very important role in this pandemic. And one of the main reasons is that we need to make sure that the true experts were giving the right information, because in a world of social media, there's a lot of misinformation going around. And so we worked extra hard, and our professionals took time, whether it be critical care, infection prevention, all of the areas that we made sure they were available to the media, and then the media got the correct story out. So I think that was another really important role that was played. Specifically with respect to cancer, obviously the regional cancer program at our reach continued to function. And even when staffing levels were lower in January because of Omicron, we were able to find innovative ways to continue with our chemotherapy, our radiation treatment, as well as with our satellite clinics, both in Aurelia as well as in Muskoka, Algonquin. And even the cancer surgeries continued. We didn't stop our mammography program. The area that I think was most hard hit would have been endoscopy itself, those endoscopy services. But generally speaking, a lot of elements did continue. There was a little bit of a slowdown, unfortunately, as we got the directive 2 with imaging as well as the scheduled procedures. So that is now ramping back up again as we got that green light a few weeks ago. So the cancer program, which is very similar to here as the other 13 cancer centers in the province, continue to run through that this time, mostly because of the professionals' commitment and our ability to continue to provide that care.
Did you do anything different, recognizing the anxiety in these patients at any time, let alone in a pandemic when,
One of the first things we did early is that we actually put in a separate screening program as you walk into the doors of the cancer center. So there'd be another opportunity to make sure everyone knew where they were going, why they were going that way. We have a lot of work done with respect to the assistants and communicating back to the patients. So I'd say of all of the areas of the hospital that were challenged during the pandemic, there was emphasis on ensuring that our cancer patients were able to get the care they needed it when they needed it. The one area that I'd say would be most difficult might have been in the short time in imaging, which is, interventional radiology, but also, of course, in some of those scheduled procedures where you're really going through the investigative stage.
Yeah. Okay. Thanks. I'm going to flip at this point to the Ministry of Health. Target for everybody, but anyway, that's okay. They have been very active. They haven't been the people that lead the Ministry of Health and Ontario Health are all very busy, I'm sure. One of the things that a lot of people have talked about is the directives that have come from the Ministry of Health. How do they get it right, or do they get it right on those directives?
I can jump in there.
Let's use one, for example, one of the ones early on, which closed physicians' offices. I think they closed. There's been 3 times where they've postponed scheduled surgery. Did they get those right, or where did they get their advice from in terms of how to do this?
I'm going to say that, did they get it right? hindsight's always 2020. It's really easy to look back and say, did they get it right? I think it's really what did we learn from this that we can do differently. If I was going through another pandemic in the future, which I pray never happens, but I would not shut down primary care. I think, using this time that we've learned to plan what we would do to keep primary care open, because of the lack of supplies and things like that, the emphasis was on keeping hospitals open and, long-term care homes safe. But we see what happened is that people didn't get primary care services. They're more acutely ill, requiring more hospital care. And really, we have the most burnt out workers in hospitals and long-term care. So if you're predicting that a pandemic will go on for this long and you put all your system dependent on one link in that system being the hospitals, it's really overwhelming, and patients don't get seen. Some physician offices are not open for anything more than virtual, and there's something that people need to be seen in person for. So those things definitely, I think looking back, we need to find a better way to keep primary care active during this. Hospitals need that support. Emergency room physicians can't do aftercare for patients, nor can hospitalists. So we really need to be able to do what we always do and pass that baton back to the family care, primary care, to be able to take care of patients. So I think that, we look at that and we're struggling still with the ramp up and ramp downs. The experience of COVID has not been the same in the province at the same time for everybody. And the ministry is obviously guarded against setting precedents. And the fact that different providers are paid in different methods. And if you shut down part and not some, it may be unequal, income earning for different professionals. But when you shut down the whole system, when not necessarily all of us need to ramp down surgeries at certain points in time, you're really telling patients to sit at home in solidarity because of one part of the province is suffering. When you're at home waiting for a hip replacement and you're in chronic pain, that really provides you no comfort to say that I'm living in Aurelia, or I'm living in Muskoka, and the GTA is in outbreak, but we have no COVID here, but I'm not getting my surgery because the whole province needs to be shut down. And if you look at Northern Ontario, going up to Sudbury and such, they were shut down right away. They didn't have any COVID up north. And now their wait times were already probably the worst in the province, and now they're double because of that. So looking retrospectively, what we do differently, I think being flexible to let different parts of the province operate while they can and not let this provincial backlog get so big would be changes. I think that, hopefully getting it right, not being afraid to be flexible in the province and not be so worried about setting precedents everywhere. I think what could be done differently by the ministry going forward.
Thanks. I had a specific question around the ministry. You've had to add staff. You've had to do a lot of things that were not in your budget, and yet you still had to carry on spending your budget for all the other things that you do. Is the Ministry of Health going to pick this up? Do you have any reassurances, or are you just waiting with your fingers crossed? What communication have you had? Janice?
Well, I think this is where the glass is half full, because one thing we have learned as a system is that we can make decisions pretty quickly when we have to. And generally speaking, they're very good decisions. And I would say from a COVID expense perspective, the money has been flowing. So we don't know what's going to happen when we're past the pandemic or into this new normal. And that's where I keep going back to sufficient operating dollars, the staff we've hired, et cetera. But through this process, it's just interesting, I think, how quickly in this crisis we've been able to move through. And Gail said, it's always easy to look in the rearview mirror and say there might have been some mistakes made. But generally speaking, I think people used evidence and science and made the best decision at the time. And it was well communicated. We were required to staff up, and we moved forward with the resources from government on a one-time basis to make that happen. So I would say that worked fairly effectively, actually. The area that I think we were a bit broken when we started the pandemic. Our foundation wasn't very strong. For example, PPE. We might forget how many meetings. I know more about personal protective equipment than I ever thought I would, because there was just no domestic manufacturers available. So all of this offshore business was really meaning that we were quite fragile when it came to something. I was wondering if we're going to have enough masks, like in the Canadian healthcare system. It didn't make any sense. We've all talked about hallway medicine, overcrowding. That meant that when we started into this pandemic, our foundation was a little unsteady. It was a bit cracked. And so I think going forward, we have to make sure that we have domestic manufacturing now. We need to keep that going. We need to make sure that we have sufficient size of hospitals, that we don't have hallway medicine, some of the things I've mentioned earlier. But overall, I thought the government moved for government pretty quickly to meet the needs and give us the funds we needed to keep going. I think the lesson is what's going to happen at the end of this pandemic period.
Mm-hmm, 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 mm-hmm. Well, there's a lot up in the air. I mean, I saw something today that talked about the way to cure the surgical backlog was to put in large surgery centers, which some people will actually say may have been the solution in the United States, in that they weren't dependent on a ward-based situation in a hospital. They had a separate institution outside where they could continue to run these. I don't know whether that'll work, but it's certainly not going to happen overnight.
And we're all going to have to find the staff, both employees and the physicians, to do the work. So you can build the building, but we're back to, I think, our greatest challenge moving forward is a health human resources crisis.
Well, there needs to be some changes. I think we can all agree on that. I did have a couple of questions that have come in here. I'll read them word for word, because Premier Ford just declared we're finished with COVID. Given the surge of hospitalizations and deaths in Denmark since that country opened up, how is your hospital preparing for the next inevitable wave? Who wants Karma?
So I'm not sure I'm prepared to declare the pandemic over, and I think all of us have learned the hard way and through experience that we need to be ready. We need to be ready. We need the capacity in place. We need to have the flexibility. We can't run, at the red line all the time and expect to be able to respond. So I think as a hospital, I think there is a desire to move forwards, and the evidence shows we can move forwards. But at the same time, and this is where the hospital and community and policy is all interacting, we need to do everything we can as a society to ensure we can continue to function properly, which means adhering to any public health measures that related to masking and distancing that are still required. Vaccinations are critical elements. So I do think we need to approach this. I appreciate everyone is frustrated and nobody wants to hear that, but there are things we can do. And it's for not just the system, but it's for the health of the community as a whole. So I appreciate the question. I think it may be too early to tell what will be next in store, and we need to be ready for everything.
Right. Where will you be cautious, Carol? Where will you kind of think?
Well, I guess what I was going to add, Keith, first of all, I was just reading, the World Health Organization has actually cautioned against declaring the pandemic over and, going on our merry way. So for sure, we have to be prepared and be ready. I would echo Janice's thoughts and comments around the capacity that has been added to the system must be maintained. We can't go back to that cracked foundation. And so the additional beds, the additional staff, and the additional funding to pay for that is going to have to be maintained. But, we've talked about the new normal and who knows what we'll end up calling that. But as we are doing our recovery planning, it is around, first of all, we're balancing response. So being prepared and being ready to respond if there is another wave, and recovery. And that recovery is built on the Ontario Health Framework of restoring services that may have been stopped for necessary reasons throughout the pandemic, sustaining some of the great new tools and ways of doing things, for example, providing virtual care, and that's not perfect in all situations, but I think we will not go back to the level that there was before. And then transformation. we won't go back to doing things the way they were before, and whether that is in some of our IPAC measures or the way that we have responded or the way that we're providing care. So all of those things I think we need to have in place to hold us in good stead for, unfortunately, another wave should that come upon us.
What's the indicator that you'll use over the next month to say, are we gaining or are things slipping? What indicator are you going to use? Maybe you'll all have the same one because you meet together, but let's Gail, what are you going to use? One indicator.
We're watching our capacity at all times to see, and so two things: capacity and bed capacity, but also capacity with our staff. How many staff do we have? We talked earlier about the fact that...
let me challenge you on the bed capacity.
Yeah.
Most hospitals have been running between 90 and 110% capacity for years.
Mm-hmm.
So you say you're going to follow that, but you'll know that it's up and down. Will you look anything more specific about the overall capacity?
Well, I think when I talk about capacity, when Carol and Janice talked about, in an emergency, things happened. Hospitals been lobbying for, alternate level of care beds to be opened in the community for decades. And, these beds were added as capacity. So the capacity exists to be able to move those alternate level of care patients out of hospitals so that we can free them up for acutely ill patients. And I think that's something we're all watching now. In a crisis, things move faster, and beds that we wanted to be open were opened. And so if those stay open, and policy works properly, patients should be able to flow through the system. As human resources are added to the system, we'll be able to discharge patients to other levels of care. And that just wasn't happening before COVID. During COVID, it became a crisis because there was zero hospital capacity and the staffing was down. So it's demonstrated that we can make it happen as a system. So, we're going to keep watching that because we've seen it happen. It's been proven. So as hospitals, we want to keep our sort of thumb on that so that it won't stop.
Janice, what are you going to use?
Well, I think the important thing is the month to 6 weeks, because to begin with, we've all found the restrictions to be really, really difficult. And now they're being lifted, and I can understand why Premier Ford they're making those decisions. But I think we have to recognize that those restrictions stopped a further increase in new cases, allowing hospitals to function. And we saw with spikes with Thanksgiving, with Christmas, and potentially with Family Day, that when people gather, 2 to 3 weeks later, we're going to see the spike. We're going to have the hospitalizations, including in our critical care units, which are really important. So we're going to be watching, and we'll know with about 2 weeks notice if we start seeing the numbers go up again, if they have in other parts of the province, even close by in Collingwood, let alone, as Gail said, now in Northern Ontario, that we're going to have a 2-week lag. And then obviously we're going to be preparing for what will be increased hospitalizations and unfortunately increased hospitalizations and admissions to our critical care unit.
Okay, so very cautious start. I'm conscious of the time here. There is a quick question about your foundations. Fundraising negatively impacted due to the poor economy, lower personal income levels. How are your respective foundations doing with their fundraising efforts through COVID? I've seen lots more advertising through COVID. I've seen that, but has it actually been helpful to the things that you need to do?
I think it's actually been, the gratitude that patients have expressed towards our hospitals. I think we've seen that blossom under COVID because of the appreciation for caregivers and the knowledge that people really want investment in their hospitals to be there when they need them. We saw that. We saw our foundations switch formats for fundraising from doing in-person events to virtual events and become experts at leveraging that technology to do different events. So I think everything changed. The foundations had to be very flexible and change the way they do things. And it has happened. And some of the things I think they'll probably keep going forward because it has worked so well to move forward with these things. So I think that they did well. And I think we all appreciate how generous the public has been towards us. We saw two things. We saw generosity towards the foundation, and I think all of us had record applications to be on our board of directors for the first time ever during COVID. So we really saw people care tenfold about what was going on in hospitals.
Carmen, briefly, your foundation, the sense of the community appreciation.
Similar story. I think the amount of gratitude in the community is phenomenal. Mutual respect and understanding trying to understand what we're going through and responding very generously, volunteering their time through the foundation, but also we've received all kinds of signals from the community, donations of food. We had in the first couple of waves painted rocks from community members that we now positioned in our rock garden in our courtyard. So we've seen that it's been quite phenomenal. And I think in general, people are reassessing their priorities as they go along. And I think all of us look at this pandemic and really take stock on what is important. And I think a lot of people have done that and look to their hospitals, look to their communities as key infrastructure that they want to support.
Nice to hear that. I asked each of our speakers if they would provide a very brief closing comment, observation. I left it wide open, except I said one thing, it probably needs to be fairly short if I'm going to fit all four of you in, which I'd like to do before I have to close. So I did write down an order here, but I forget where I wrote it. So Carol, do you want to go first?
Sure. Thanks, Keith. I guess what I would like to reinforce is, and people know this, mental health and physical health go hand in hand. Can't have one without the other. There is no question that the pandemic has exacerbated mental health concerns. There was a recent poll by CMHA Ontario which they repeated several times early in the pandemic. About a third of people thought their mental health had worsened, and just recently in the last week or two, half of the people polled said their mental health had worsened. So that's a serious concern. In an early schematic of a pandemic, it showed mental health as the fourth wave, and unfortunately people thought of that as sequential, but actually when you looked at the diagram, it started immediately after the first wave. So, certainly I think your next session, Keith, will be very timely. More than 60% of parents said dealing with the pandemic has been difficult for their children. Employers as well have a role to be supporting. We've talked about that for healthcare workers, but employers have a role to be supporting their folks. That many have employee and family assistance plans. I just encourage people, if they're struggling with their mental health or seeing a loved one struggling, to reach out for help, either EFAP for healthcare workers. Waypoint is one of 5 hospitals in the province that's offering a COVID frontline wellness program. So that is available on our website. And, I mentioned employees broadly. There is a standard from the Mental Health Commission around having organizational wellness. And so that's some work that we are trying to lead regionally in Ontario Health Central across all the hospitals. So really,
great.
Yep,
great.
really reach out. And although we've talked about our challenges, we are all here. If people need help, reach out, as Gail had said earlier.
Right. Janice, key message?
Well, thanks very much, Keith. I mean, it's been a really grueling 2 years. And again, just that very deep thanks to all healthcare workers, our hospital partners, other partners like public health and long-term care homes, as well as, of course, paramedic services. The frontline workers have been under grueling, extreme circumstances. And I think it's good to note that healthcare has never really been an easy job. It's been a little bit harder in the last 2 years for sure. But everything that people have done is just really nothing short of heroic. We think that every member of our team has been affected by this, and they've all worked together to do the very best thing for the patients entrusted to our care. So I'm leaving RVH at the end of June as I retire. Been here almost 18 years. I've been a healthcare leader for 35 years, and I've never seen anything like the last 2 years. We're going to take the best of it as we get out of it. We're going to have to learn some lessons from it. And certainly I think that how we've all responded, including our leaders who I've mentioned earlier tonight at that middle management level, it's been really inspiring and humbling to be able to be in this position during this pandemic. Please let's use common sense as we begin to reopen again.
Thanks, Janice. Gail?
Thanks. I think my message will be a little more future oriented. Every hospital in Simcoe County, including obviously those of us here tonight, have huge master plans in for our hospitals that were to build new centers from over the 10, 15 years to deal with the expected, doubling in population size for most of us. And with the migration we've seen during COVID to our areas, that it is troubling about building enough capacity in the shortened time frame. We may need that capacity now. We saw the population increase dramatically. So what we predicted would be 10 to 15 years from now that we would have to serve as hospitals could be a few years away now. So that's something that we're all looking at now and trying to plan for the future, how we deal with this sudden growth in population as a result of COVID.
Okay. Carmine.
Thanks, Keith. Thanks for having me. And I'll leave with two key messages, one of gratitude and to my team, to my colleagues, all their teams. I think everyone has just risen to the occasion and continue to do so. And I really do appreciate and all the community supports in our audience for participating tonight and asking the questions. I think this dialogue is absolutely critical. So gratitude. And my second message is around balance. We are learning so much. The worst thing we can do is overreact in any direction. We need to take that cautious approach. I think there's so many positives coming out of this, and we have to look very hard for those silver linings because it has been very difficult. And I think we will be better coming out of this. We have the plans in place for recovery. We've tried them out a couple of times already. So we will continue to do so. And I think looking forward, I remain optimistic. I think there's lots to be gained from this experience. And I will take away that positivity and that learning opportunity. And hopefully with the right balanced decisions, we can move in the right direction.
Great. Thanks for all of you for saying what you did say so carefully and thoughtful in such a short period of time. So I appreciate that. I do have to wrap things up. I could go on forever. Our questions are many and I didn't get to them all. I apologize. But the one thing that I want to do in closing, and this really echoes comments about the appreciation to our healthcare workers, is to say on behalf of the community, because I feel that this program does represent the community and many things, please take home the message to your people at your hospitals. I shouldn't say your people, the people who work with you in your hospitals, for all the tremendous work that they have done, the angst that they have gone through and continue to go through for keeping all of us safer and healthy. They've all done a tremendous job and are going to continue to do that job. So on behalf of all of us in the community, please send that message back to your staff. To our audience, I hope you've enjoyed our event tonight. We've certainly appreciated having you with us. I have one message for the audience, and I think you know what it is. Get vaccinated. That's the one thing that has not changed throughout this pandemic, the cry for people to be vaccinated, how it will protect so many, including our healthcare workers and our children. So it gives me great pleasure to say thank you to our speakers. You've been wonderful. It's been nice to get to know you again and learn what the challenges you went through. Gail, your comments about future growth around that as the GTA has moved forward, we can all see that. Thank you. Carol, the importance of mental health and the things that you've done in your organization to make sure that those services are available for staff and the patients that need it, and getting that message out where we get those services. Thank you. Janice, good luck in your retirement. And I certainly have said we echo your thoughts about how to support staff, how to say thank you to staff. You've done a tremendous job. You have a wonderful team. You all have wonderful teams, but we need to recognize that. And you must be very proud of the organization that you're leaving at the end of the year. So Carmine, balance. Key message here as we go forward, balance, right amount of positive, the right amount of angst, where do we go? So thanks for that comment on that. So, and all of you. Also, thanks to our 7 sponsors. If you'd like to watch this program again, you can simply go to the MCC Our Health website, tell your friends you can watch it, and we'll see you again in 7 weeks on April the 7th. Will the kids be okay? See you then. Good night, everyone.
Thanks, Keith. Bye-bye.
Thank you.
Call the Rogers TV viewer response line, email us, or connect with us on social media.
I'm Wendell Clark with a word about winning. We all know it takes a team effort in any sport and with any challenge. You can be a part of the winning team that shuts out impaired driving. Whether you're out on the town or just hanging out with friends, drink responsibly. Always have a plan for a safe ride home for yourself, your family, and your friends. You'll be helping to shut out impaired driving.
Visit ArriveAlive.org to find out more. Arrive Alive. Drive sober.
What were Umbrella doing here?
This is where they're experimenting on him.
We gotta get out of here.
You gotta help us, Claire. Let the world know what's really going on.
We have to contain this.
My grandfather was a Ghostbuster.
This thing is real?
What did we let out?
I think we opened the gates of hell.
You're watching Rogers TV, Midland.
What's up, everybody, and welcome to Inside the Game, your source for everything in the world of video games. Now, of course, you can always be a part of our show by going to InsideTheGame.ca or hitting us up in Discord, where there you can submit your clip and be the highlight of the week. What's coming up on today's episode? Well, here it is. It's the rundown.
Run, flailing their arms, trying to get to you, which is a little unnerving, but it didn't make a whole lot of sense as far as story is concerned. The story is definitely the main focus in this game, so I'm not going to spoil anything, but
Steve, this week we're hopping into Gravitational on Steam VR. You were playing on your Oculus, and this is an interesting one. I kind of actually had high hopes coming into this game. It's about...
What does Sony do to counteract this massive